So over the next 30 or 40 minutes, we shall be discussing a few cases of scenarios which we see commonly in our clinic, in our day-to-day practice. So let's get started. And after every case, once we have done with a particular case or a particular topic, I shall be inviting some questions from the audience as well to keep it two-way. And this first case is a 42-year-old male, new onset seizure, non-focal examination, large non-enhancing right frontal mass. So let's start with simple things first. So can I have the opinion from the neurosurgeon? Dr. Manas, I think, is here. Yeah. So what should be done? Should we do anything or can we observe?
No, first is surgery in this.
I think you are not. No, this is not working. Mic, please.
Yeah. Here the first option will be surgery. I mean, there is no other options. After surgery, it's most likely it's better to exercise totally and then go for the next step.
Well, yes, indeed. And the rationale for surgery, of course, you're seeing a bit of mass effect. You're relieving that, as well as the seizures. I think that could be relieved up to 20 to 30% of non-enhancing. There's a non-enhancing tumor, but 20 to 30% of these could be high grade on histology. And also these days, we're talking of molecular and biological information to guide treatment. So indeed, an extensive radical resection was accomplished, and only a small, approximately 10% residual T-2 FLAIR was remaining subsequently. Histopathology was grade 2 oligodendroglioma. So if we have only the information of a grade 2 oligodendroglioma, are we good enough to decide and go further, or do we need some additional information? Can I request Sajal to?
Grade 2 oligodendroglioma, then we will be going further with biomarkers.
Sorry, the mic is on.
So we will be going for the further biomarker study for 1p19q co-deletion, and then we'll plan for the further adjuvant treatment.
Dr. Tanmoy?
Sir, what's the question, please? So do we need anything else?
Should be right there.
Hello.
Any other panelist wants to comment on this? So do we, should we rest with the diagnosis of grade 2 oligodendroglioma as of today, or should we certainly do something more?
Oh, I think I think in our group we tend to have a lot of discussions about these particular kind of cases, and oftentimes it comes down to institutional biases and patient preferences. As the radiation oncologist in the group, I'm usually the one advocating for adjuvant therapy rather than watchful waiting. And especially in this patient who has several high-risk features already. And as someone who has, with the co-deletion of 1p and 19q, can have quite an excellent outcome with adjuvant therapy. So that's usually been my argument.
So indeed, this patient was co-deleted 1p19q IDH1 mutated, third promoter mutated, and MGMT methylated, and was given additional treatment with a combination of radiotherapy and chemotherapy in view of the high-risk phenotypic types such as male, age more than 40, residual disease. So this patient indeed was treated with radiation and chemotherapy, and of course we have supportive evidence from RTOG 9802 which tells us that such patients do indeed benefit if they are treated with a combination of radiotherapy and chemotherapy to the survival tune of benefit of 60% versus 40%. If you treat with RT alone versus if you give additional chemotherapy, there's an absolute additional survival benefit of around 20% or so. But the next question is that can we give chemotherapy alone in low-grade gliomas? Dr. Tilali, could you take that question?
Actually, you chose a very good case. The molecular profile is very favorable. Although looking at the MRI pictures, it is most of the times such favorable molecular profile doesn't exist. In such a largish tumor going towards the corpus callosum, there is invariably some aggressive feature on histology. It may be called still grade 2, but invariably you will see islands of highly cellularity, slightly more aggressive, atypical features. Otherwise, and the age, of course, is more than 40. The interesting question would have been if the patient's age was 35 or 37, and then what would you do? And the residual disease is less than 10%.
We would be debating through the night.
Yeah, so that would have been very interesting too. So one could, of course, give both, as was mentioned, but that we do get in our clinical practices too. Coming back to the question, so people have given temozolomide and still give quite a bit. And we are showing this study as well. This study has kind of been published later because this would have been much more important before the RTOG 9802 study, and this was Brigitte Baumet started this study many years ago. And that study, of course, showed either you can give radiation or temozolomide, but there are two arguments which are against giving temozolomide alone. First of all is the data from RTOG 9802, which is not directly with temozolomide, with PCV, but it basically says radiation plus temozolomide plus chemotherapy, and only radiation and or the chemotherapy is not as good. So that is one. And second is the concern which I showed you in my presentation is this, it's a relatively small group data as at the moment, but there is this concern that only temozolomide would cause a lots of mutations in future. And this was based on a comparative cohort from UCSF that they had the primary grade 2 tumors, and when they recurred, they did the analysis again, and they were treated only with temozolomide. And the mutation risk was more than 2,000. So that is a concern. And if you speak to other people, they say if you combine with radiation and temozolomide, then perhaps the mutation will not be so much, although not proven. So most of the people would not give temozolomide alone anymore.
So all the panelists agree that we should use a combination of radiotherapy and chemotherapy in this case. Yes. And is that the take-home message? Now, taking this trial a bit further, we all know that the outcomes of radiotherapy arm and temozolomide arm were kind of similar in this trial. But what was kind of interesting and intriguing was the radiotherapy arm seemed to do better in the IDH mutation non-correlated group. And is this important from the radiation oncology perspective, or does it have any clinical implications for management of low-grade gliomas?
You know, I think for us, because I think for us, we've always advocated for radiation, and so, regardless of the population. So I think, this is a little bit more data for us to hammer our medical neuro-oncology colleagues with, but I don't know if that makes a big difference for us.
Yeah. The other thing that, again, I'll come back to this trial only because updated version of this dealt with the quality of life issues, and the question is, does RT cause more quality of life deterioration than temozolomide? Does RT alone cause more quality of life deterioration than temozolomide alone? And intuitively, one would say yes. And however, this publication, again from the same group, told us that at least for 3.5 years, the radiotherapy arm and the temozolomide arm were actually going neck to neck in terms of quality of life, although they used URTC QLQ30, BN20, and mini-mental examination, but they found an equality. So any comments from the panelists on this?
Well, it was known before, if you give focal radiotherapy, it's data from Dutch studies, and there was no deterioration with focal conformal radiotherapy. The only deterioration was when you use higher dose per fraction. Although a follow-up by Martin Klein's paper in Lancet did eventually show that there was some deterioration in 1 or 2 or 3, I think, domains among the 13 or 15 odd domains, 10 years post-radiation point of view. But this doesn't really surprise. The greatest determinant which we have to realize is still the tumor, not the treatment. And that has been increasingly shown that tumor is much more important to cause even neurocognition and quality of life. And the control of the tumor with radiation would keep a lid on it. but it is with data with, I would say modern conformal radiation will be even better than the data that has been presented here.
Okay, so my next question is actually very, very seminal and very, very important because it deals with what you are going to do in the clinic. So we all say that, okay, we have to give CT-RT, we have to combine chemotherapy and radiotherapy in low-grade gliomas, but for a particular case or for cases that we see in our OPD, I would request Srinivas maybe. So what would you do? I mean, would you follow the STOOP protocol? Would you give RT followed by temozolomide sequential? Would you follow the RTOG 9802 and give RT followed by PCV? Or would you make you have made or something your own regimen?
Ideally, it should be subject.
I mean, I want a consensus message to be sent to the audience on this issue because this issue is bothering everyone these days, that what is the schedule that has to be used in low-grade gliomas when you are going for CT-RT?
Ideally, this question should be subjected to a clinical trial, but of course, every question cannot be answered.
Till the time
exactly.
Results are there,
I know.
We have to
Ideally, it should be, but in a clinic, of course, the evidence overwhelmingly has, randomized, at least randomized evidence overwhelmingly favors PCV. But in a clinic, I would really follow something like a Stoops protocol, mostly like Stoops protocol rather.
So, Stoops protocol. Does anyone differ? Does anyone have a difference of opinion other than Stoops protocol?
I will follow 9802, but we'll give temozolomide. RT followed by temozolomide.
So you will use sequential, RT followed by temozolomide.
No, what if
I wanted a consensus.
If it is a
Dr. Jalali.
If it is oligodendroglioma and 1p19q deletion, then I will do radiotherapy followed by PCV. If it is a grade 2 oligo with 1p19q co-deletion, then I would go for radiotherapy followed by PCV, based on RTAG 98102.
See, there are, as we know, there are issues with PCV in terms of availability, in terms of...
How to also say that the PCV that we use in India, fortunately, is a modified PCV based on the MRC protocol, and we have been all taught in all our institutions, which is much safer than the classic PCV. So that way, it is not such a big deal. The consensus, although we may say purist is PCV, but the whole world is following temozolomide.
And so are you.
And so are we. What we do slightly different is, I mean, it is not proven, it's just our own thing. Instead, in anaplastic oligos, we don't give 60 gray because you give, especially if they are favorable 1p19q, and sometimes we have seen late-term toxicities. We only give 55.8 gray plus temozolomide, but this is our own thing. But most of the people would give concurrent plus temozolomide, I think. And based on the RTOG 0943 study as well, it's a single-arm study, but that's an important study.
Okay, and next follow-up, another important question. Is there any group, subgroup, where we can avoid further treatment in low-grade gliomas? If there is, can you please go ahead and define?
Yeah, so there's...
Dr. Robert.
Yeah, so there's data on exactly this issue where patients who are younger than 40 and have a gross total resection with low-grade glioma can be safely followed for rather than receiving adjuvant therapy. So I think there is such a group.
As I mentioned, 30 patients, we are in a prospective study. We are observing them. All are less than 40 with good resection with favorable molecular profile. In our country, though, compliance is very important and also a good histopathological. Sometimes you get only one small sample, maybe grade 2, but there's obviously an enhancing component. So if you overcome all these variables, there are many patients which can be observed as well.
There was a natural history trial as well by the neurosurgeons, and based on the gross total resection, the amount of tissue which is left, they saw the pattern of recurrences as well as the chance of the probability of recurrence. And those who had less than a centimeter had close to 30% recurrence, 30% progression within 5 years.
Why I specifically asked this question, that if you go back to my RTOG 9802 slide, in which they actually left a group saying it is low risk and we'll observe it, and they randomized the high risk group into 2 arms, they left a group, which is the low risk group, and they just observed it. What happened to that group is this. Among that group, half of these patients of low risk cohort, which nothing was done, they recurred in 5 years. And then they went on to prognosticate this group as well. And they said, okay, preoperative tumor size more than 4 centimeter, residual tumor more than equal to 1 centimeter, and so on and so forth. So do we have a consensus on which is a truly, or we're still evolving?
My comment on this particular, as you mentioned, half of the patients in the low-risk group actually progressed. Probably, I think, if I'm correct, if I've read the paper correctly, the molecular classification was not performed on these low-risk subgroups.
It was not done, agreed.
And the conventional low-risk, I think, should now give way to the molecular classification rather than, the typical smaller-sized, younger-aged patients. But we do see those rare situations where the molecular group is in a higher subgroup, even though other clinical factors and other prognostic factors favor a good subgroup.
Even the traditional URTC randomized trial by Karim et al. Also showed that the progression-free survival obviously is better if we give radiotherapy followed by surgery followed by radiotherapy, and as compared to surgery followed by observation. Even the long-term data also showed that progression-free survival was always better
So
with
basically, we are still in the process of crystallization. We are still in the process of, with the advent of molecular, in the process of defining which that group would be. Okay, moving on to the molecular oncology in CNS tumors, especially gliomas. Everyone agrees that grade 2 and grade 3 gliomas are kind of closer than ever before since the advent of molecular oncology in CNS tumors. And this is just a comparison between, for example, astrocytoma and anaplastic astrocytoma, grade 2 and grade 3. And we can see the equality of percentage mutations of IDH1, MGMT, and so on in both astrocytoma scenario as well as oligoastrocytoma scenario. So this is one more message that is coming from the studies, that we have to go beyond the traditional grade 2, grade 3.
I think you're absolutely right. So
previous oligoastro, either oligo or astro.
yes. So yeah, you are right. So oligoastro is
Combination of, sorry.
I just wanted to make a point that we are working very hard that almost all labs in the country should at least do ATRX and IDH. And as I mentioned, they each cost about 1,000 to 2,000 rupees only, and it's an IHC based. Occasionally, you may have to do sequencing for IDH to confirm if it is negative, and there's a strong, morphologically, you are looking like an oligo. And you don't actually need a 1p19q, which is expensive, about 9,000 rupees. So if it is ATRX loss and IDH mutated, then it's likely to be an astrocytoma. If it is an ATRX loss and IDH retained, and IDH mutated and ATRX retained, likely to be oligo. And these are the guidelines I think we should all adopt.
Okay, before we wind up case 1, any 1 or 2 questions on low-grade gliomas that anyone from the audience feels that has not been covered or wants to ask to the panelists?
If the audience doesn't have, I have a question. I didn't understand what is the consensus on observation in low-grade glioma to observe. Because though 50% recurred, but the overall survival, whether we give upfront radiation or a delayed radiation at recurrence, is similar. So so is it not worth waiting for the low-risk patients observe and give radiation only at recurrence?
For low-grade gliomas, the trial which you mentioned, early RT versus delayed RT, the thing is very complicated because you will not see an overall survival difference because of salvage RT was offered in majority of the patients, and that actually confounded
Delayed radiation.
the results.
Okay,
Yes.
we have one
That's why
question
survival
from the
there was no
audience.
difference.
Dr. Gatami.
Yeah, means
You're not audible. Yes.
The issue of the radiation effect and the chemotherapy effect, the comparison of the cognitive effects. I think in the short term, you may get away with it. In the long term, the radiotherapy group do worse, and in particularly the oligodendroglioma tumors. If you follow them up, there is a phenomenon of cystic degeneration that goes on in the radiation field, and they do cognitively a lot worse. So radiotherapy effects are not to be taken lightly. So you have, particularly in the oligodendroglioma tumors, astrocytoma does not seem to have this effect. Only oligodendroglioma, you see the cystic degeneration causing dementia-like syndrome in the long term. If you follow them up 10 to 15 years, they're going to survive 15 years or even longer. They're going to suffer a lot of side effects, and the quality of life issues need to be taken into consideration. I'm not saying that you don't do radiotherapy and chemotherapy, but the radiotherapy versus chemotherapy, there is an issue. Chemotherapy on its own is less toxic, but may not be as good in terms of survival. So, and the second issue is PCV versus temozolomide. Now, in younger patients, PCV is more toxic in terms of fertility issues, and in females particularly, the early menopause issues are much greater. So if you are treating oligodendroglioma tumors in younger females and males, fertility issues and early menopause need to be taken into consideration if you are giving PCV chemotherapy. Temozolomide is much better in that group, in my opinion.
Okay, thank you for your comments. We now move on to the next case, switch gears to a patient who is 69 years.
So one more. I want to ask one more question.
There's a question there.
Yes, I want to ask a question.
Yes, yes.
Why concurrent temozolomide has not been tried in low-grade gliomas if you want to intensify the treatment?
We have
Is there any
advocated this
role?
2 protocol, haven't we?
Concurrent with radiation? But that's what we were talking.
That's
so
what
there
we
is
are
a
saying.
There's a RTOG trial, 0424, which saw aggressive low grades, more than 40 years of age, large tumors, and if they had significant residual, they gave radiation plus temozolomide, concurrent and adjuvant. But it's a single arm study, and the survival rate was 3-year survival was 73%. And they compared with a historical cohort which were treated with only radiation, and that was 54%. So it is not like a level 1 evidence, as is in RTOG 9802, but there's an increasing acceptability of this protocol in high-risk low grades.
Thank you, sir.
Okay, this 69-year-old lady presented with right hand weakness for the past 2 months. MRI suggested a lesion, left parafalcine. Looks like a high-grade lesion. Investigated, operated, post-op residual tumor, non-enhancing, involving the splenium portion, histopathology GBM, KI 20%, MGMT positive. Offered adjuvant radiotherapy, temozolomide, standard ways, the STOOP protocol. Now the question again, we had a bit of discussion in the talk also about this. But how would we draw the CTV margin as of today? And is there a case for reducing margin of CTV in high-grade gliomas? Dr. Robert, you would like to take that first?
Yeah, sure. So I think, again, as I mentioned in my talk, those of us who are trained on RTOG protocols, still continue to...
What we can practice? How much margin reduction can we practice in day-to-day clinical work?
So, I think those of us trained that way are continuing to use, 2 centimeters on the gross disease for the boost volume. It's becoming more and more acceptable to use smaller margins, right, down to 5 millimeters, assuming that you have a good handle on the imaging studies that guide this contouring.
Dr. Jalali?
Fortunately, in India, most of us were not trained to give 2 centimeter margin beyond T2, not the RTOG. We are more kind of a European that way. That has traditionally been the practice.
Yeah. I guess, so I think that as well requires pretty excellent imaging. The difficulty that we always have with the STOOP protocol is that you can have, non-enhancing components of the tumor that can look just like edema. And so you have to make a determination whether that's tumor or edema. And that can be difficult.
Yeah, so that's a good point. But we tend to include all the T2 weighted changes or FLAIR abnormalities. And there are 2 indirect evidences. There was actually a beautiful study done in PGI Chandigarh, Narendra and Dr. Sharma and Dr. DP, which compared an RTOG protocol vis-a-vis the EORTC, the European protocol. There was absolutely no difference. And the other indirect evidence is from the centric trial, the Salenji trial, and Srinivas and we were talking. and it was a multi-century throughout the world, and they had the opportunity to see the North American center data as well as the European data. Again, no difference.
No, I think that's
So there is a
you're
case-
right.
Yeah.
no,
Yeah.
I think that's part of the reason for the consensus protocol is the recognition
Okay.
that everybody's okay.
Next question. This patient received 6 cycles of adjuvant temozolomide. September 2013 finished. MRI suggested 1.5 centimeter residual disease. At this stage, would you stop temozolomide, continue temozolomide? If so, for what duration?
So my question is, do you know MGMT status?
MGMT positive,
Methylate.
Positive.
methylated.
So in that case, there is a case for continuing temozolomide up to 12 cycles.
So what are the factors that at 6 months will enable you to determine that, okay, I should give for 6 months more? Srinivas?
I mean, the MRI information which you give is definitely insufficient for me to take a decision. But if I have a continual response, there is some data that 12 cycles is actually better than 6 cycles. Of course, it is more of a population-based data, as you're from Canada. Different provinces actually treated for 12 months versus 6 months. And actually, there is some data that 12 months is actually better than 6 months. So I would definitely be tempted to, for a person who's not shown any progression, at 6 months, I would definitely continue for 12 cycles.
So for patients who are doing well, are methylated,
Tolerating well,
stable, are tolerating, don't have too
Progression.
many issues with counts,
I would be tempted.
we can
yes,
continue for
12
6 more
cycles.
months, up to total of 1 year. Okay, this patient was doing well. In September 2013, there was a 2 centimeter residual oblique recurrent lesion in the left parietal region, but the perfusion values had almost doubled compared to before. So the lesion size had increased from 1.5 to 2 centimeter. The perfusion values had almost doubled. So at this stage,
Yeah.
what are the options for us?
In methylated patients, I mean, the progression so fast is something which is slightly unusual. And the perfusion which you've just said, whether it is actually significant or not, although it's increased compared to the previous one.
Could be a pseudo progression also.
Yes, so I mean, the perfusion value probably alone wouldn't be the only criteria for me to take a call on whether the disease is progressing. So I would probably look at MRI much more carefully before I take a decision whether it's real progression.
So suppose you decide it is real progression.
It is a progression within 6 months, am I right?
No, it's been,
Oh, you said 2013
Yeah.
itself.
yes,
so
more
it's
than 6 months,
6 months.
Yeah.
Close to 6 months.
I mean, I guess this is quite the issue, right? That we see
Yes.
this quite often changes this amount
So
of
it's
time.
a small lesion, it's a 1.5 or 2 centimeter area.
Yeah,
It is
so
showing
we always have
it's
this
showing
discussion whether
perfusion.
this represents true
So what
progression.
would you do?
It's always discussion is whether this is true progression or the radiation oncologists get blamed, right, for post-radiation changes. And so for our group, we've tended to rely on DOPA PET for these issues as the tiebreaker and whether to call it as progression or not.
Dr. Soman, you want to say something?
Dr. Monshia, what I would like
So the message here is, of course, perfusion you can, but never take just one value.
Yes.
Always better to observe these patients, don't jump the gun very quickly, especially as Srinivas said, it is methylated. And if you have a serial, at least 2 or 3, sometimes even 3, I must warn you, sometimes what happens is that you get a high perfusion level. We have had several cases where the perfusion CBB was even done very nicely, and with ASL was 2.5 or 3, and which is high, right? But when we actually looked at the pre-treatment, it was actually 6. So you also have to see the gradual, it may be high, but we have to compare with the baseline. So we would almost never ever take an important decision unless we have 2 or 3 serial MRIs
imaging.
and also the clinical deterioration.
Any other comments on this?
So it's a 1.5 centimeter to 2 centimeter with some suggestions of increased vascularity. So in this situation, I would possibly wait and do another scan in 2 months' time to
And then take a call.
ensure it.
Okay. Any question on high-grade gliomas from the audience? None. So we move on to case number 3. And this is an 11-year-old boy, a known asthmatic on treatment, presented with headache, fever, diplopia for the past 20 days, MRI done. September 2012, posterior fossa mass abutting the brainstem. underwent craniotomy with wide excision. Post-operative histopathology was medulloblastoma classic. CSF analysis, no malignant cells. Post-operative MRI of brain and spine, no residual disease, no metastasis in spine. Final impression was standard risk medulloblastoma. And this patient was planned for craniospinal irradiation, concurrent chemotherapy, and adjuvant chemo PACA regimen. This is the treatment schedule of craniospinal irradiation, 23.4 in 13 fraction, local boost, 32.4, 18 fractions. Okay, this was 2012. We are now in 2017, and I want to know from the panelists how differently they would approach this case in management in 2017. May I begin with Sajal?
Sir, in 2017, we would try to do the molecular profiling of medulloblastomas. We will try to see the molecular subgroups, whether it belongs to Wnt, as was suggested in the last lecture also, the Wnt pathway or the sonic hedgehog or group 3 or group 4. Though the treatment probably will not change as much as of now, but maybe in the time to come in the future, maybe the treatment would be tailored according to these molecular subgroups.
Dr. Soman, your turn, finally.
Yeah. So if we have a patient now coming in with a medulloblastoma, we do the molecular classification. If it's a Wnt, like we talked about, we are now decreasing radiation to 18 but that's as a part of protocol. I've treated 3 patients who came for proton radiation, but we are following that. If you have a sonic hedge patient, which is simple, we have a GAB1 and we identify as a sonic hedge, we treat it standard risk or whatever, but the question remains whether we need to do maintenance. We have treated 2 patients who continue on maintenance of vismodegib. If you have a group 3, group 4, so the way we get an answer from St. Jude's is a Wnt or a sonic edge or a non-Wnt, non-sonic edge. So if I have a patient walking in today who has a group 3 and group 4, how do I manage this patient? So not only we do the total treatment, but we are planning to do an adjuvant treatment as a maintenance, because the maintenance arm of Aracy has stopped of the cis-retinoic acid. So we will do an hypomethylating agent. Either we can do some sort of vorinostat, or we plan to do with a vorinostat with decitabine, and the sick children is following that. I think that's an option, because group 3 comes back, and if it comes back, you lose the patient. And group 4 is slightly better. I think that's the way to approach.
Okay, we are running short of time. So yeah, we talked about these groups, Wnt, SHH, group 3, group 4, and their classification. My quick question to Dr. Manas, who's our neurosurgeon here, and I want to ask him, after these groups have been made, has the surgical outcome or surgical approach changed for medulloblastomas? Because there is some bit of evidence emerging, and I'm sure you must have gone through this trial. It is a kind of a retrospective study only, but it tells us that if you do a subgroup kind of an analysis, maybe in group D, it is much more important than in Wnt and SHH. So that classical system that we had of gross total, near total, subtotal resections, is it kind of, do we have to approach it differently for different groups?
Means the grouping is after your molecular marking. So the first surgical option will be extent of excision. But in this era, we increase the extent of excision by using fluorescence. We use yellow fluorescence, we use ALA fluorescence also in medulloblastomas to increase the extent of excision. But it will not change the surgical plan, maybe in recurrent. Yeah.
So the standard of care is still to achieve gross total resection. This was the very large 750 plus patients accrued in the Lancet Oncology paper, and they showed the GTR was better in group 4, not in other sites. So whether it is STR, subtotal resection, it was still a subtotal resection versus, it was actually a near total resection versus a gross total resection, and there was no difference. So what we do in our practice is we of course now have every patient, we have 350 patients now accrued. The only practical, it needs time, as you know. We have to see how it impacts the treatment. What we do, Showman, here, what we are going to do now is for Wnt pathway, we are going to launch a study called FOR-WINT, which is only focal conformal radiotherapy to the posterior fossa. We are not going to do CSI, and we will salvage them with on-tomotherapy if need be. As a prospective study, we need 55 patients. For group 3, group 4, and including large cell anaplastic histology, Tejpal is going to do a continuous hyperfractionated accelerated radiotherapy with concurrent carboplatin, along with adjuvant. And with sonic hedgehog, we'll try to throw in some markers. So the practical solution now at the moment is only in WINT. I know we have time, so I'll just tell you. So if you have a WINT pathway confirmed on a histology, and there is a small residual tumor, especially going towards the CP angle, so classically it is a high risk because there is residual tumor. But in WINT, then you don't need to give 35 gray. You can go away with 23 point. Not validated as yet, but we have done it in few patients. And from surgery point of view, there is this radiogenomics data, including our own data now of 130 patients, that we have 66% accuracy in WINT, 95% in SHH based on MRI only, and overall accuracy is about 70%. If you do have a suggestion of WINT either on MRI or as a second look, if it comes to you, then perhaps there is no need to go again. And WINT, as you know, are the central tumors near brainstem. And if the radiogenomics does get validated robustly, then one could perhaps be a little bit more circumspect in towards the brainstem. And in other sites, you have to do gross total section.
Okay. So we have run out of time, I feel, and but any final comments or take-home message for medulloblastoma patients? Dr. Soman, you want to say something? My question is, any take-home tips for medulloblastoma from the session? Yeah.
Medulloblastoma.
No, you are not.
So to summarize, what is it? So to summarize, I mean, if a medulloblastoma, we should do molecular classification, number one. Number two, we can decrease radiation. I don't know about surgery. That can be feasible. It's easy to do. But for the group 3, group 4, I would suggest doing some sort of adjuvant. If you can do vorinostat, desitabine, and do a prospective study. It is so easy to do here in India versus us.
My only small, humble request to everyone is to be sensitive about medulloblastoma. Try to get the molecular profile done. Within a year or so, we will identify at least 7-8 centers throughout the country. It will be presented in the ISNO, who will do either an IHC-based method, or our RT-PCR TMH assay, which will cost only 6,000 to 7,000 rupees. And as I said, we'll be happy to do free of charge for any patient in the country. The reason is that eventually we will do it in practice after 3 to 4 years, as we do typically in India. But why not do it now and preserve the data, do what you are doing, but in 4 or 5 years, the treatment is going to completely change. And then we will start doing
we could analyze our
so
own
why not
data
do prospectively right at the beginning?
Yes. So I think we are done with the session. Any questions from the audience? We'll take only 2. Here comes the first one.
My question is about the concurrent carboplatin for patients with medulloblastoma. So I was just listening to Dr. Hanumanta's presentation where he was saying that, the toxicity might be an issue when we are using carboplatin concurrent with radiation. I thought there were a couple of papers which kind of, really pushed for the cause of, usage of carboplatin. So I just want a comment on that. Is that something that we have to use now for every patient with medulloblastoma, or are we okay with giving just vincristine weekly when we are using radiation?
So in TMH, we have done a study of 60 patients. Dr. Kurkure is probably going to speak with us. And now we have more than 250 patients. These are all high-risk medulloblastomas. Initially, we were also skeptic whether they can pull it off. We can pull it off with CSI, and we used to give only for first 15 fractions rather than the full CSI. But we have a very large data now to show that it is very much practical. You have to use growth factors, of course, for almost every patient. But the data is very encouraging. The EFS in a high-risk medullo, including large cell anaplastic and medulloblastoma and metastatic, is 67%. 5-year EFS, so it's pretty impressive that way. And there is, of course, the COG study as well. So in very high-risk medulloblastomas, metastatic, perhaps group 3, group 4, large cell anaplastic, maybe P53 mutated SHH as well, you could possibly give carbo, and it is feasible in our country.
Okay, one final question from Dr. Kurkure. Final question.
No, I was just responding to his question, and Dr. Rakesh has
summed up
covered it,
well.
but we were skeptical to begin with, but it is quite manageable in our circumstances as well. With the large volume of patients also, the outdoor care and in between admissions for some platelet transfusions and all that. Barring that, there is no problem.
Okay, thank you. We had
It has a IV infusion every day.
Yes, just before, 1
Every
to
day
2
before
hours
radiation.
before radiotherapy.
Okay, we had planned for 2 more cases, brain metastasis, acoustic neuroma, but we have run out of time. I think we'll leave it for another day. And with that, thank you all very much for your very wise and I think the messages for the audience, for take home.
Dr. Kurkure has a question.
One question can I ask? Somebody showed that there is a advantage initially when you use the targeted therapy, and that advantage disappears. I don't remember who because there are so many presentations. But this has been the case even in hematological malignancies when we have used the targeted therapy. A classical example being CML. The resistance develops because cellular ingenuity is very high and they find out the way. So has resistance being studied now already in this targeted therapy for various brain tumors? Because there is an advantage to begin with which tails off. And ultimately, you don't get any survival advantage.
I think Dr. Tejpal
Now we can discuss that during
was in relation to
the
immunotherapy.
inauguration program, and Dr. Reddy has raised his hands thrice in despair. So with that, we conclude this session, and thank you all very much.
Thank you so much for those thought-provoking